Hi, my name is Katie, and I'm excited to present to you the Quality Improvement Project that I have completed. It is about improving handoff communication from the operating room to the post-anesthesia care unit. This project addresses a communication issue that has a real impact on both staff workflow and patient safety. I'll walk you through the background, identified problems, literature evidence, and our plan for improving the handoff process using a structured, evidence-based approach. Why communication matters. When we talk about communication in healthcare, we often think about patient education or teamwork. But one of the most critical moments for education and communication is during care transitions. These moments are fast-paced and time-sensitive, and the quality of information exchange can directly affect patient outcomes. The transition from the OR to the PACU is particularly vulnerable to communication breakdowns. In the operating room, priorities are focused on surgical completion and moving quickly, while in the PACU, nurses are preparing for immediate post-operative monitoring and stabilization. If information doesn't flow smoothly between those two spaces, critical details can be lost. This project aims to reduce those risks by standardizing our handoff process with a structured communication tool, helping ensure every patient receives safe, timely, and appropriate care. The identified problem. What's going wrong now? Currently, our OR to PACU handoffs lack consistency. Depending on the nurse, the surgeon, or the time of the day, the report may be detailed, or it may be missing key details like blood loss, last medication dose, or specific concerns from anesthesia. Our PACU nurses have reported that they often receive patients with little to no context, which leads to delays in care, mistreatments, and avoidable calls to clarify information. Smoot 2021 points out that appropriate handoff communication is essential to ensuring patient safety. When we don't use a standardized tool, the risk of patient harm increases, not just due to medical errors, but also because of communication gaps that slow down urgent care. Staff input and real-life examples. In my interviews with my PACU colleagues and my leadership mentor, we repeatedly heard the same things. Information is inconsistent, handoffs are rushed, and staff feel unsure about the reliability of the reports they receive. One nurse shared that a patient arrived with no mention of a significant blood loss during surgery, which led to confusion about why the patient's vitals were unstable. That's a powerful reminder that we don't just hand off patients. We hand off critical knowledge, and we need a structured, reliable system to do that. Root cause analysis, the 5 whys. To get to the bottom of this problem, we use the 5 whys technique. This is what I found. First, nurses often skip or rush through parts of the handoff. Why? Because the tool isn't user-friendly or enforced. Why isn't it enforced? Because there's no training or accountability tied to it. Why hasn't training been done? Leadership assumed it was being used properly. And why didn't leadership catch the issue? Because just the breakdowns haven't caused major measurable patient harm, just workflow disruptions and staff frustration. The true root cause is a lack of structured training, accountability, and feedback systems. The tool exists, but without clear prompts, active monitoring, or leadership prioritization, it's not being used effectively. Aim and the SMART goal. The goal of this quality improvement initiative is very specific. We aim to increase the compliance with the standardized SBAR handoff to 90% within 3 months of rollout, targeting a completion date of October 1st, 2025. This is a SMART goal: specific, measurable, achievable, relevant, and time-bound. Our focus is not just to implement a tool, but to actually improve how reliable we transfer patient information in real time and reduce the variation in how handoffs are performed. Measures and how we'll track the progress. To evaluate our success, we'll track both process and outcome measures. Our primary process measure is compliance with the SBAR tool, meaning our staff consistently using it during OR to PACU handoffs. Our outcome measures include fewer handoff-related incidents, fewer delays in PACU care, and improved satisfaction among PACU nurses, which we'll measure through brief surveys and audit checklists. Monitoring compliance regularly will help us fine-tune the intervention and make adjustments in real time. Why standardized handoffs work, and this is where I talk about my literature review. The evidence strongly supports our strategy. Research consistently shows that structured handoff protocols reduce errors and improve communication. For example, Wang 2021 found that structured handoffs reduce omission errors, meaning fewer important details were left out. Abelbaum 2024 confirmed that standardizing handoffs decrease preventable adverse events, including medication errors and delays in care. Methacool 2019 showed that improved clarity with SBAR use, and Brissett 2023 demonstrated that checkoff list-based tools led to more complete reports and better recovery outcomes. These studies validate that a clear structure like SBAR leads to better patient care. PACU pause and barriers. One model I found particularly helpful was the PACU pause, which promotes a calm, structured handoff environment. Surveys 2022 reported that the PACU pause not only improved safety, but also increased nurse satisfaction. The takeaway is that structured benefits both the patients and the staff. That said, many studies also report barriers, such as inconsistent training, distractions during handoff, and uneven expectations between departments. As King, Shamby, and Abraham 2023 found, when nurses receive reports without clinical context, they lose situational awareness, and that directly increases safety risk. Our plan aims to tackle those exact issues. Plan for change. Our intervention is to implement a standardized SBAR-based handoff protocol. This includes updating our electronic health record system, which we use Paragon, with required SBAR documentation fields. Providing staff with printed tip sheets, reference cards, and wall posters to reinforce the progress. Re-educating all perioperative nursing staff to ensure they understand how and why we use this tool. Importantly, this is not just about policy, it's about embedding a cultural shift that values consistent, clear communication at every level. Staff education and engagement. Training is a huge component of this project. We'll hold mandatory education sessions for all relevant nursing staff and ensure that new hires are trained during orientation. But beyond education, engagement is key. We'll use real-time audits to identify top performers and recognize them during shift huddles or team meetings. This reinforces positive behavior and builds momentum around the change. Monitoring feedback. Nurse leaders will audit handoffs using a simple checklist that evaluates whether the SBAR tool was used and whether key contents was communicated. We'll provide feedback on 101 and also report trends back to the group so we can identify challenges early and support improvement. The stakeholders are the quality improvement leadership, the nurse educator, OR, and PACU charge nurses, frontline staff, and our IT team. The budget is minimal, $1,000 and $125 to cover training materials and minor electronic health record updates. In anticipated outcomes, we anticipate a significant improvement in handoff and communication, leading to faster, more efficient PACU care, reduced errors, and increased staff satisfaction. In the long run, we hope this model can be adapted for other handoffs within the facility and helping to build a more reliable communication culture. In conclusion, this quality improvement project isn't about fixing a workflow, it's about protecting patients. Even though we have tools in place, we're not using them effectively, and that's putting people at risk. By implementing a structured SBAR-based handoff, supported by training, feedback, and leadership, we can improve safety, reduce delays, and strengthen the continuity of care from OR to PACU. Thank you for your attention, and I am welcome to your questions and feedback.